Welcome to today's session. Our WebExes are always meant to be focused on issues we're commissioned to do from our colleagues in the Policy and Strategy Directorate, but this is an area that we've become particularly passionate about, and over the next hour you'll learn more about what we've been doing and how the system works and how you can use it. But the amount of work that has gone into refreshing this simulation model by the team has been phenomenal, and I'd particularly like to thank Phil, Julie and Jamie from the team who have supported Claire throughout the whole of this year with really trying to progress this. So I'm really excited for you to see it.
I'm Julie Renfrew. I'm a delivery support manager working on the long-term conditions year of care commissioning team. And as Beverly said, we've been working very hard over the last few months with CCGs and Simulate to help develop the simulation modelling tool and to add functionality and to make it more user-friendly. A detailed video is now available on our website on details of exactly what the tool contains and how to use it. And today Claire and I are going to give you an overview of actually what the tool does and how it works. So what I wanted to start with today was why use a simulation tool. So it's to be used really to test before you commit. So it doesn't give you all the answers, but it points you in the direction of where you might want to go to ask further questions, to allow you to assess variation in terms of what is the likelihood of under and over performance. So there's cost information in there, and also resources, to look at the likelihood of too many or too few staff. The primary use really for the tool would be for scenario planning. So what would be the impact of a proposed service change? Will it save money? Will you need more staff? What additional services might be needed or reduced? So moving on to the next slide then, what does simulation actually do then? The simulation model will allow the simulation models how people with multiple long-term conditions use health and social care services over a typical year. So services are associated with costs and resource use, both staff time and bed days, and thus the tool outputs results in terms of activity, costs and resources. The patient cohort that you select for testing using the tool can be segmented in up to 4 groups, with each group having a different likelihood of accessing services over a year. You can also run the simulation now for up to 10 years. Previously it was 3 years, and patients may move between groups as the years pass. New patients will join the patient cohort and patients will leave the cohort if they die or leave the area. The simulation aims to represent the way in which these groups of patients typically use services in all their complexity and variability, and you can test the impact of changes in service models prior to implementation to understand the likely impact on cost, volume and resource use. So who should use the simulation tool then? It's really to be effective, both those making decisions and planning service changes should use it in conjunction with their informatics and IT professionals who will be more interested in the baseline information within the tool, manipulating the model, interpreting and sense-checking results, whereas service managers, commissioners, finance managers, etc. from both commissioning and provider organisations the simulation will help provide pointers and guidance of where to look next. I just want to tell you a little bit about the underlying data within the tool. So there's a vast amount of data supporting the tool, and I don't want to go through it all, but it's basically based on a lot of work done by one of our LTC Year of Care Commissioning early implementer sites, Barking, Havering and Redbridge, or BHR as I've put down there on the slide. And it's their whole population data over a 3-year period, looking at patients who have the highest risk score, so their top 10%. As I say, it's split across 4 resource usage categories, So that 10% is broken down further between across very high to low risk categories and looks at various areas of service. It doesn't actually include social care data in there, but built within the model is the ability to add your own local data where this might be available. So there's lots of distributions based on the DHR data built into the tool, which are likelihood of patients accessing the service, the number of times a patient might attend or is admitted or has a contact, costs and resource use for each attendance or admission. So the baseline data within the model, it also includes expected or anticipated changes over time based on the work by BHR. We've built into the tool the likelihood of leaving a cohort, death or leaving the area, new patients entering each of the different categories, and the transition between the resource categories. So there's a wealth of data in there, and when I go have a look at the scenario ability that's built into the tool, you will see that you can use the tool and all the data in there to map where you are, but you do need to have a look, and you might want to go into the detail of what differences, local differences there are, maybe between activity types, or whether you want to look at a different proportion of the population. So at the moment the tool focuses on the 10%, but it's very interactive, and you can change and manipulate all of the information that's built within there. I'm now going to pass you over to Claire, who's going to talk you through how the tool actually works.
Thanks very much, Julie, and it's great to be here, and we're delighted to have got to this point, and thanks to the team for all their support of us as we've been building this tool. I think it's probably true to say that the real purpose initially of this tool was to try and allow people to understand what it was like to be an early implementer. There's 4 years of experience now in this program, and what we've been doing is building the simulation alongside of that is a way of really accelerating the learning for people who haven't been part of the program for 4 years, so that they can understand what people went through and they can test those sorts of models of care for themselves. So it's a way of hopefully accelerating those fast followers into the program. Okay, so the way that we understand this is that when you're looking at your cohort of patients, you've got your first cohort, which so if you just go back to that last slide, thank you. Your first cohort, which are probably your lowest need patients, and from the data what we've been able to ascertain is that there is a likelihood that they will access those different services as Julie explained. So hopefully that picture gives you a bit of a sense of it. But as that person transitions through age and gaining new conditions and maybe becomes more frail, then they start to need the same services but with different likelihoods and probabilities, and you can see those there. Now, what we've done is we've replicated that in the simulation. You can use your own data to look at those likely probabilities, but you can also use the default data that's there to just get a sense of what that might mean. If you could just move to the next slide, please, Julie. Thank you. So what's driving the model then is that group of patients by level of acuity, and what happens is that they transition between different states. So we might start off with, say, 100 patients at that low state, but at the end of year 1, perhaps 15 will have moved into a medium state, which means that they perhaps have 3 or 4 long-term conditions, maybe 5%, maybe 5 of them will have moved into the high, maybe 2 into very high. And as they move into those different areas, then they start to need different levels of services, different frequency of services, and each of those services has a cost associated with it, and a capacity associated with it. So what you're doing with the simulation is replicating really the way in which your patients move through services according to their need, and of course that changes year on year. You can bring new patients into the simulation also year on year, and also people will leave the simulation, and at the same time they're accessing different numbers of services, and you can of course look at the way in which those services might change by testing your redesign ideas within the simulation. And for analysts, and I won't go into that in a huge amount of detail now, but you can see that there are lovely spreadsheets that you can fill up with your own data to put into the same model. And in our guides to you, what we've suggested is if you haven't got 4 years worth of data, here's some of the data from the early implementer sites you might want to use as a proxy whilst you're collecting it. But there's some data that you will be able to put in immediately, like, for example, your population and the cohort of patients you're looking at. Thanks very much, Julie. So what I wanted to look at now was the results that you get from the simulation and why, in fact, it might be useful to use it. So one question you might have is, how should I set the tariff for different patient types? How does that compare against reference costs? So by running the simulation, you get these kinds of results. You can see the number of patients there are in each group and how that changes over a number of years. And that graph at the top left shows you 3 years worth of patients. And then you can also see the, if you go back to the last one, please, Julie. You can also see the average cost per patient in each of those groups over 3 years. So you can see that varies against a bit. And then you can compare that with the tariff that you wanted to set. So you might be looking at a tariff of around 10,000 for your very high group of patients. You can see there for that that's not going to be quite enough in year 1. It'll be all right probably in year 2. In year 3, you'll need a little bit more. And you can also compare that, because you're looking at actual cost there, you can also compare that against your reference cost. So what is it you're paying for each service? And how that fits as well. So really it allows you to test your different scenarios with those financial kind of results. And if you just move on to the next slide there, Julie, thanks. You can also drive down into individual types of activity. So I'm showing you the results specifically for the A&E department. So again, you can see who's using the A&E department in each of those patient groups. By year, you can see the resource that they're using. So in this case, we've said, well, let's look at a key member of staff, and you can see the patients in each state. So you've got that comparison, and you can see the costs. So one of the questions you might want to ask is, okay, if I bring in an enhanced GP service, for example, and I expect that that will reduce my activity in A&E and also knock on to non-elective admissions, what does that look like? What does that look like in my cost and activity hospital services? But very importantly, what does it look like for the resource that I'm going to need to deliver that if everybody goes to their GP 3 times instead of going to the A&E? Resource need in the GP practice, and what are the overall cost implications? So it allows you to have a high-level view and also to delve down into some of the detail. So if you can go on to the next slide, please, Julie. Okay, so I'm going to hand back to Julie now, who's going to talk through some of the scenarios that you can run.
Thank you, Claire. Okay, so the reason I've got baseline and scenarios here on the title slide is that to effectively understand the impact of a service change, you really need to look at where you are now and then run what your service change might look like. So it's understanding the differences between the two, really. So what we've got within the model is some scenarios that are built into the tool, and also an option for you to create your own service change. So within the tool, we've got 2 scenarios. The first scenario is based on evidence from the Scottish Multi-Morbidity Programme, which effectively looks at the link between number of long-term conditions and avoidable emergency admissions. And this results in anticipated reductions in acute activity and anticipated increases in community or primary care activity. And those differences, or that service change, is the scenario that's been built within the model. So as I've said, it won't give you the outputs, won't give you the answers, but it does give you some direction on whether the new service will be cheaper, how much cost would shift from acute services to primary care and community, for example, how many new community mental health and GP practice staff might be needed. So the second scenario that's built into the tool is based on introduction of a care navigation service. And the fundamental elements of the approach that's been built into the tool is set out there. And again, this will result in service shifts that we've built into the model. So the major differences between scenario 1 and scenario 2 are that scenario 2, i.e. the one I've just been through, the care navigation service, focuses only on the very high-risk category of patients, so the top 2% of patients, whereas scenario 1 would look at the impact across all 4 categories. So the really interesting thing, and what you can do as well, sorry I didn't mention, is you can pick up those scenarios, but you can tweak them, so you can amend them slightly, but use the basis of the underlying information that's there related to those scenarios. You can also create your own service change scenario as part of the tool, and a wizard will walk you through how to actually create that and take you through whether you want to make proportional, what you reckon the proportional adjustments will be, the proportional impact will be to reduce access to attendances or other services. So you would enter the total percentage proportion of your population that you wanted to have a look at that a service change relates to, and then it would walk you through the service scenario change wizard. So, for example, you might want to have a look at the impact of an enhanced GP service on A&E and emergency admissions, and you would anticipate a reduction in the acute activity. So I'm going to hand back to Claire again, who's going to talk you through some of the additional features of the tool. As we've said, we have spent quite a lot of time trying to make this tool add more functionality and make it more user-friendly. And so, Claire, do you want to walk through some of those additional features?
Yeah, thank you very much. So for those people who've used it before, and so might be familiar with some of these things, you'll understand why some of these things have changed, and very, very grateful to those people who've been testing it for us and testing some of our new things, and also giving us feedback on how it feels to be a user, because really without that we don't have good intelligence that we need to make sure it's as user-friendly as it can be. So the first thing I wanted to say is that you can now export all your results to a formatted spreadsheet. And I showed you and talked through some of those results before, and you can just flick from service to service. As you can see on the under where it says provider and service, you can change each service that you want and service area that you want to look at. I think that makes it a lot easier to do your analysis and to immediately see what the impact is on any change that you want to bring about. So we hope that's going to be much more powerful for you in viewing those results. If you can just move to the next one. The other thing that you can do is you can run multiple runs and you can compare them side by side. So you can see here that that's been done. So you can, at a very high level, you can get those cost comparisons. So if you're looking at those different runs, you can see that run 2 costs slightly less than run 1, and then run 3 is, really little, and then back to run 5, which is about the same. And you can also compare how those costs vary across different provider types and service types. So where they've stayed the same, where there's a variance, where that's gone up or down. and the aim of that really is to help you to not just look at whether the overall spend fits the needs of your patients. It's also to be able to discuss with all of your stakeholders where the costs are falling as a result of the changes, and how you might want to use that to negotiate with different providers around how to provide services and contracts. So if we go on to the next one, the other thing was we originally had this as running for 3 years in the future, but a lot of people said to us, well, actually, we really do need to look a bit longer than that. We want to run up to 5 years. So what we've done is we've set 3 time periods that you can run through. So you can still run just 3 years if you like, but also if you want to run up to 10 years or up to 5 years, any period into the future, you can do that as well. On to the next slide. And we've also put in incidents, so you've got your population, and with that change in those 10-year population, of course, we've got population growth, mostly growth, and you have projections in for that, but you can also look at your expected new patients in each year. Now, there's a default in there which is based on the BHR data, because obviously they've been able to, just go back to that slide. That's what we've been, the data's already in there. So if you haven't been able to measure your likely incidence of the patients in the cohort you've chosen, then you might want to use BHR data as a proxy. But you can also put in your own incidence. Thanks, Julie. Next slide. We've also put a number of different cost functionality in there. So as I explained, you can set your service costs against your actual costs, and you can set that whole variation of cost depending on the service and who's accessing it. But you can also put in your reference costs, so you can compare those against your actual costs. You can compare that against your tariff, and you can also put in likely inflation or deflation. So hopefully that will give you the richness that you need to make some really good financial decisions. We've also put in a facility to test for capacity and resource. So, for example, if your rate limiting resource for a particular service is beds, then you can set your activity against beds, and then say how many are available, the time, sorry, that's spent in each resource, so the time that's spent in bed for each state, and the results that you then get show you the number of bed days that you would need. And the same thing with staff. So if you expect that a GP is going to spend 20 minutes with a very high patient and maybe 10 minutes with a high patient, you can put that in, and then the tool will calculate for you with all of your what-if scenarios how much GP time they're going to take when you look at all of those patients as a whole.
Okay, thank you, Claire. So how do you actually access the tool then? Well, the version that we've just been talking about, the upgraded version, is available online now. You can download it to your PC. You will also, in the next day or so, be able to use it online via the LTC Year of Care website. To support you, a detailed how to use the tool step-by-step video is also available now on our website, which walks you through in a very detailed way how to use the tool. But you don't panic. It's an hour long in total. You don't have to sit through it all. You can flick to different sections to allow you to get some more detailed advice on how to actually use the tool. They're also available are Quick Start and Analyst user guides. So the Analyst user guide, again, will be very detailed, and the Quick Start guide is primarily aimed at service managers and those using the outputs from the tool, I guess, and a frequently asked questions document. And the documentation supporting the tool will develop as we move forward over the next month or so. We are also, so that version that I was just talking about available on our website is free to download and to use and to access, and all the functionality that Claire has just been through is available within that tool. If you want to go one step further and you want to be able to share your simulation with colleagues via an online portal, you would like individual coaching from Simulate, and to access a data template for easy upload, there will be an upgrade option available directly between, the relationship would be directly between yourselves and Simulate, and there would be a small charge for that service. But all the details of that will be available on our website, and obviously use of the free tool in no way commits you to the upgrade option. So just in terms of a contact there from Simulate, Claire, I don't know if you want to say a few words to finish off and just to summarise the contact details there.
Yes, thank you very much. So you can access us through that email there, and also do call us. Don't please get stuck with it. If you know, there's obviously there's lots of different people asking lots of different questions, and we probably can't assume that we can anticipate them all. So please do feel free to give us a ring and talk to us. The last thing we want is for you to use this and not be quite sure. Hopefully all the user guides and the videos and everything will give you everything you need, but don't hesitate. We want you to make the best use you possibly can and get the value from this. So don't suffer in silence, tell us, and also just tell us what your feedback is, because that will help us make tweaks to it to improve the experience for everybody. So thank you very much.
Interesting to hear from people on the call as to whether this makes good sense, if there's anything obvious that we've missed, or where you could use it in your current work, and how you might want to use it. I also know a very good colleague and friend of mine, Katie, is on the line. So Katie, from a patient perspective as well, if you would be interested in giving us some input for that. It's always interesting to see how these things that we're doing at strategy level work at a personal level, and how they can support some of the changes hopefully people are trying to make, as well as organisations. So on that one, that's not really for discussion, it's more it is what it is and it does what it does, and people can connect into it and use it for what it is. So that might be why we're not having quite the questions that we would expect. Sherry, brilliant, thank you very much.
SDNs and NHS England are working with Sarah Marsh and Thames Valley, looking at improving neurology services in the community. And we've been a bit of a dilemma with how to compare possible future innovation with current service provision, and I think this will be a useful model. I would like to learn more about how to use it. And I guess the team that I work with would be interested. And it was really how do we get somebody to come along to a team meeting?
Yep. So how do we get some capacity to support you to, one, understand what the model can do, and then how you might apply it and use it in your neurology services? Is that a good summary? Yeah.
Brilliant. Yes, thanks.
Brilliant. Thanks, Sherry. So I guess, Claire, just to go back to you, I mean, in terms of using the model, we can certainly support you as much as we can, and Claire may have to do the clever bits with you. But Claire, using it for neurology services, what would your thoughts be on that?
Yeah, so I think, I mean, that's I suppose the basis of this model has obviously been to think about people with multiple long-term conditions. So if you use neurology services, you're probably using other services as well, and look at that complexity. But there's no reason why it shouldn't be used for looking at people with just one condition. What I would suggest you do is you look at, if you want to look at subgroups within that, you can do it and look at that transitional area, or you can just keep them to one group, which indeed one of our scenarios has done, and then just test the scenarios within that. it's perfectly possible. The first question really with this, or indeed any simulation, is to think about the questions that you want to answer. So what are your service redesign ideas that you want to put in place, and then think about the population that's going to most likely be receiving those, and start from that point. So you've got all the population inputs that you can put in, which can relate to the population you're interested in, and then it's thinking about how you model those redesigned services. But certainly you could use it for that. But also, I think from the national programme, we'd probably be wanting to encourage you to think about the comorbidities for that particular population as well.
Yeah, definitely. I mean, a lot of our modelling innovation is around community. So although it's neurology patients, yes, as you said, we've got comorbidities. So it's around the vanguard and supporting the new models of care, which particularly the multi-community providers, I think. So yeah.
Yeah, that sounds like a very, very suitable use then.
Thank you.
Great, that's brilliant. So we'll come to Katie next. If we can just unmute you, Katie. I know we've got your question, but if you want to pose it direct yourself.
Thank you. I was just wondering if patient feedback was recorded during the process of the simulation, and what was that feedback like?
Good question, Katie. I knew we could rely on you. Claire?
No, I mean, the groups that we worked with, I mean, this has obviously gone on over 4 years, and it's been looking at the types of services that patients would access over a typical year, depending on who they are. So we've been kind of feeding, if you like, or fed with the information from the people who've been testing that, who have been working with patients. I don't believe that patients have actually seen the simulation, and it would be very useful perhaps to test that out, particularly if you're going to make a decision with it, to see if those ideas are recognised in any way. We've done that with other simulations, but I think it's very much been used at a local level, and patients have probably been involved in that at that level, but we haven't done that at the build level, no.
So that sounds like we might have found you a job, Katie.
Always, yeah, it'd be great to have that input.
Okay. Yeah, good. And then Yvonne, who, Claire, you may remember, Yvonne was a cornerstone of Southend early implementer site for a long time, and has now moved on to Castlepoint and Rochford CCG. But Yvonne, welcome.
Thank you. Can you hear me?
Yep, perfectly.
Yeah, good. Claire, it's really in relation to the work that Southend did, and I just wondered whether any of the South East ethics data had been run through the model, or whether it was just Southend.
No, it hasn't been. It could quite easily be, though, yeah. Because I think all the time we were building the simulation, we were looking at the experience of different sites and saying to ourselves, is this going to fit for each group, and getting different groups to feed back, because obviously what we wanted to do is to make it as make it able to be as specific as possible to local sites, but at the same time where the parameters were the same. So certainly, I mean, if you go to that website, you could, and that data is available, then you can do that now.
Right. I mean, it's just really useful. I mean, I'm now working on integration and transformation in Castlepoint and Rochford, and we are being asked so many questions around what is our transformation programme going to deliver, and it's really tough, and people are looking for instant results, and you just don't get that when you're transforming systems. So I'd be really keen to use it to develop some of the work, particularly around our care coordination programme and some of the work we're doing around our integrated hubs. But thank you.
Okay. No, well, it'd be nice. It'd be great to see you especially having had all that experience at Southend.
Thank you.
Brilliant, thanks Yvonne. Okay, so there are no more questions at this point, so I'll just summarise by saying the slides and the recording and a couple of other links will be available on our website either later today, or some elements of it later today and some tomorrow. So we will make sure you all get a link to that. But please do let us know either if you use it or if you're interested in using it and how you plan to, so we can help support you in the best way that we can. And I'll leave the final word to Claire and just say, Claire, what's the one or two things that people can do the minute they come off this call that can start them on their journey of using this model?
Well, thank you. So the first thing I'd love you to do is to go to the website and get hold of the model and download it or use it online. We know that downloading things and installing them in the NHS isn't always fantastically easy, which is one of the reasons why we've made the online model available. So hopefully one way or another you can use it. And what I would say is, from the experience of the users, is don't panic too much. If you look at it and you see that there are some data requirements, there's a really good user guide for your analysts which gives them everything they'd ever want to know. So if you're not the analyst and you're the service managers, just hand them over that document and get them to read it and use it. But just press the run button and see what it does and look at the results, because one of the great things about simulation is that you're not going to hurt any patients or any staff or anything by running a simulation. It's literally there to give you some enlightenment, to help you think through your problem, and hopefully to allow you to test some of those things without any risk. So don't be scared of it. If it doesn't do what you expect it to do, just tell us. That'll be our problem, not yours. So just use it, I think.
Brilliant, I like that. Don't be scared of it and just use it. I think that's a really good motto. So I'll call this WebEx to a close. I think that's been fabulous. Let's just see how you can use it, what you can do with it, and we'll look forward to coming back together in January on the 15th for our next WebEx. So thank you very much, everybody, and thank you to Julie and Claire and to Phil for all their hard work. So thank you very much and good afternoon.